screen, guys. So perfect. You start recording it, right?
Yes.
Okay, good. So let's see. Cool. Nice. And if you guys have any questions about any of the concepts that I'm going to speak about, just stop me and we can go over them, or we can do the Q&A at the end. As I said, my name is Juani or Yanni. And, I started freediving back in late 2014 when I took my first class, and in 2015 I went to Vertical Blues to just be a volunteer and watch. And then I happened to meet the medic who really introduced me to initially the medical part of freediving. I started seeing things that I haven't ever seen in clinical practice in a hospital or in a clinic. And then I decided that that's really the sport I wanted to be in. Seeing blackouts, or what we call freediving related syncope, or seeing samba, or what we call loss of motor control, or tremors, or hypoxic fits in neurology. It was like almost like a lab, meaning a lot of things that I haven't seen years and years and years in training in neurology. I was able to see them in freediving, and that's really sparked my interest in this. I want to dedicate this as well to Carla Hansen, who left us being the president of ADA a couple of years ago. And she's the person that I really owe learning a lot of things in freediving, and not only starting as a medic, but also just jumping from being a medic to being a competitor in my very modest records from my home country of Peru. And yeah, I want to dedicate this to her. This was back in 2016 when we met in Florida with Rob, who as well, I have to give lots of credit. Rob King is an amazing instructor here in Florida and all over. So my disclosures are that I don't have any financial relationships with any companies or any businesses that may appear in this lecture. And I think the most important thing, I'm going to assume that the lecture today is for beginner freedivers, since that's what initially I planned for. And I think it's very important to know why we freedive in the first place. I think freediving, it's a sport that grows differently in different countries and different parts of the world. And I remember perhaps in 2015, 16, I was going to dive at the local spring, Buford, when you have to walk through a swamp for about 20 minutes to get to the spring, and then walk back to a swamp. And now it's totally different, and things have changed, and people are using nose clips and lanyards and looking for safety. The things are changing a lot, and I hope they are changing for the better. I think freediving is an activity, any activity that involves breath holding underwater, and should never be performed alone. Freediving is meant to improve your physical and mental condition. It can really change and improve your life. And it's very important to know that we only know the very basics, very basics, very baby steps of freediving physiology and freediving medicine as of 2022. You know, what we see in freediving medical conditions, we learn it from basic science research published, peer-reviewed journals, but a lot of it is from talking to the athletes. And as a physician who wants to learn freediving, you have to be on the field learning from the athletes. There was a very good, very famous surgeon in the US called Halstead, and he said that the way to teach medicine to students is to be at the bedside with the patient. So the best way to learn freediving medicine is to be next to the athlete, no question. So as a physician, I tell my friends, if they want to learn freediving, you have to listen to the athletes. Number one. This is just to show you what, as of maybe a month or 2 months ago, or perhaps more, a little bit more, the records all over the world, and what limits of human condition are pushed, seeing depths of past 120 meters, 130. Then it tells you that the more the records are pushed to higher limits, the more freediving medicine will be relevant and will be responding to situations that are potentially dangerous. And therefore physicians or medics that have to be in these situations have to be prepared. Just a brief, I don't, since, you know, this is a big group today, it's not really no more beginners, but I have to give credit to Aid International, from where I learned everything I know on freediving. So just because today, this year is the 30th anniversary of ADA, I have to give a lot of credit to that that agency. Again, never dive alone. Know why you freedive. Seek methodical training, and put safety first always, and always look for a buddy. So the general freediving physiology is something that you learn on your courses, but I want to go over some concepts that are important to know: why you feel when you do freediving well, and why you feel bad when you don't, when you have an incident in freediving, and how you can explain your symptoms. The idea of doing this to the community is so the community is able to explain things and come to conclusions that are safe without having a physician on site, and without having a nurse on site, or respiratory therapist on site, or a medic, which is probably 95% of the times you go training in a remote area. You don't need you won't have a doctor on site on the beach or the platform or next to the buoy, but you need to have just some very key concepts to be able to know when it's safe or when symptoms are good or bad. You know all this, you know the diving reflex, bradycardia, peripheral vasoconstriction, central hypertension, splenic contractions. I don't need to tell you too much of this, but the main focus of the dive reflex is to preserve the brain function. And I make the analogy of the brain being the pilot of a plane. And when the pilot sees that there's low on fuel, then the pilot starts throwing away luggage and maybe turning one engine off and turning the other one off, and then you're flying on fumes. So the dive reflex preserves not only adequate delivery of oxygen to the brain and adequate delivery of blood flow to the brain. The brain has specific mechanisms to regulate blood flow. It's called cerebral autoregulation. So the brain tells your body, I need more oxygen and I need adequate blood flow. And that's what your body changes underwater, and assures that there's adequate blood flow to the brain. So you don't need to know this. You know probably from basic freediving what is RB, total lung capacity, tidal volume. But this is just to have an idea of what you need to know to just understand basic physiology. And obviously you don't need to remember this chart, but this is good for medical professionals to understand why, for example, training in RB or training in FRC is different than training in total lung capacity. And believe it or not, most physicians that do, let's say, Western medicine are very neophytes, or they really don't know how to assess of someone that has had an incident in freediving or a history of incidents in freediving. The diving reflex was discovered or described many, many years ago, 1700s. And the main stimuli is pressure, cold temperature, that triggers trigeminal afferents to the brainstem. So the brainstem is a part of our brains that is the most primitive part of our brains, archaic brain or reptile brain, to keep us alive. You know, brainstem is the part of your brain that really keeps you alive, and that's what triggers the diving reflex. There's receptors in the carotid artery. I think there's somebody that is not muted, so I'm gonna ask you guys to mute yourselves.
Hey, Johnny, I think I muted you by accident. Hey, Johnny, can you hear me? I think you're on mute.
How about now? Can you hear me now?
Yes.
Okay. Little sabotage. I get it. Can you hear me now, right? Yes? Okay, good.
Yeah.
So just going forward with the dive response, when you start on the early phase of apnea, literature describes that your heart rate and starts dropping, your plethysmograph changes. And this is a basic literature that's already published to describe how your partial pressure of oxygen decreases and your partial pressure of CO2 increases when you dive. Your mean arterial pressure also increases when you dive after a certain time. And this varies from person to person depending on age, cardiovascular status, medications, diabetes, mean arterial pressure, etc. So, and this goes to teach the instructors how to assess risk on your students. Because not all your students will be in the same physical condition. And even if they look like they could do the same or be in the same physical condition, it's good to know if they're taking medications, for example, or if they had an incident in the past. Even if they're fit, they may have a cold cardiac condition that you may want to know about if there's history of that. When we, let's see, these are all diagrams from old books and research done by Enzo Mallorca and his family describing bradycardia with time of apnea. So this is also a published paper last year describing the dive reflex and how cold temperature on your face triggers not only bradycardia, also deep breathing can trigger some bradycardia, and even Valsalva maneuver as well, and elevations and changes on your mean arterial pressure. Now, why your mean arterial pressure is important and why it's important on your students. If your student has a history of heart disease or heart failure, taking medications for heart conditions, and you're trying to go and do a session of, let's say, 20 to 30 meter dives, then you know that their mean arterial pressure will increase, especially at the end of the dive. Why? Because when you're going at depth, your brain is trying to elevate the cerebral blood flow. That means that your brain is trying to increase the mean arterial pressure to some degree. And if that's an issue for your student, then that may become a risk. You need to assess it. The reason why I say this is because when a student goes to any agency, let's say, they have to sign a medical release form and a medical statement. And it's only a tool to catch the obvious medical conditions that may affect freediving, not all medical conditions, because they ask you yes and no, yes and no, yes and no. And then if you answer yes to anything, then a doctor has to look at it and sign off for you to go and continue freediving or enter freediving. But that form and that questionnaire doesn't catch the occult medical conditions like patent foraminal valley, cancer, God forbid, or carotid stenosis, or airway disease. And now that plus the fact that most physicians don't know about freediving, it's a recipe for not catching a lot of things that can happen in freediving medically. Splenic contraction is another mechanism that is involved in dive reflex, and this is well published, even from '85. So it basically is a fresh source of red blood cells injected by a contraction triggered by stimuli. And that stimuli can be not only trained, but the trigger can be trained by athletes, and also the response can be augmented with time. For example, beginner freedivers can have splenic contraction because they hold sweat-attention, start doing 1, 2, 3 dives, and they get splenic contraction. But dive reflex is at least subjectively felt by some athletes just by looking at the water or putting their wetsuits on or just getting barely wet. And that's something to say how a biofeedback affects freediving in regards to your changes in your body and biological triggers. There's plenty of literature to show splenic contraction. I do not know of anyone that has had an splenectomy that had issues going at depth, although I don't know many athletes that had their spleens taken out and report having issues. If you know of any, please let me know so I can learn from you. And this is an article published in Science some years ago describing the Vajau community, where they compared this community that lives off of freediving comparing to other communities around them. And they discovered that they have 50% bigger splenic size than the surrounding communities. And they actually linked that to a gene. And that tells you that this is adaptive evolution, because they require freediving, they need freediving to survive. Now, blood shift is part of the dive reflex as well, and involves central hypertension, meaning increase in blood flow to your core, to your lungs, heart, central vasculature, and that increases your cerebral blood flow. That's very important, because as long as your brain has adequate cerebral blood flow, then your brain function will continue normal. But anything that will affect your cerebral blood flow can trigger changes in mental status in freediving, syncope. And if that happens, that's bad, because that's a recipe for either loss of motor control or samba or syncope or blackout. Now, why this is important? Because central hypertension is explained by the increase in blood volume in the core. And as you can see here, this is a diagram that is in all your books. If you go to 20 meters, 30 meters, then your air volume on your lungs decreases and it's replaced by blood, which is blood shift. I'm not going to go into this because I think the science of training is perhaps not my forte at all. And I can tell you probably some, but not mine. So the basic ritual for performance freediving is avoiding stimulants, no big meals, 2 hours before diving, sometimes some say 3 hours on morning stretches. We're not going to go into that because that you can take that from better sources than me. Mental techniques, attention deconcentration, thought and awareness, third-party observer, thought control mantras are something that you can learn from very experienced people like Alexei and William, and others are in the audience as well. The relaxation phase is known as breathe up, but now we call it more like a relaxation phase, because you're not controlling your breathing, you're allowing your body to breathe at tidal volume, which keeps your CO2 at normal level. And this is interesting because packing is something that, for example, is not supposed to be taught in most freediving courses, but because it's done in freediving, especially in competition, it's something that you need to be aware of, because not only has some risk factor to it, but it can improve not only your ability to equalize at depth, but also your ability to get deeper without getting to RB, your residual volume. And this is interesting. This is a spirometry I did at the hospital for myself. And I was able to pack, my total lung capacity was like 6.6, 6.7 liters. And I was able to pack over a liter, a little over a liter just by packing. And even packing with the spirometer is difficult because you're breathing through a tube. So you cannot really hold it. I bet that if I measured it without that tube, with a spirometer, it would be more like 2 liters of packing. This was packing, let's say, 15 packs with the machine. But if I did that without the machine, I would do 25 packs. It would probably close to 2 liters, which tells you how much you can do with packing, but how risky is packing as well. Like in this case, for example, of a case that shows a pneumomediastinus, which is air around the heart. That can happen when you do it on dry, when you do it on a pool, or when you do it just before depth diving. So careful with that. Other physiological observations, possible treatment of dive visit for supraventricular tachycardia, which is an arrhythmia of the heart. And what is interesting is at depth, the partial pressure of oxygen increases, but the partial pressure of CO2 does not increase as much or as expected as your change in partial pressure of oxygen. And this is why was hard to learn when I was trying to make sense of this freediving physiology. This is why when you're in a pool and you're doing, let's say, 100 meter of dynamic with the monofin, you're having contractions, right? Urge to breathe. But if you're doing, that's 100 meters, that means, let's translate that to depth. And if I do depth, let's say 50 meters will be 50 down and 50 up, I get 0 contractions. If I try to do 100 meters, which is 50 at 50, I will be having significant urge to breathe and at least a bunch of contractions. So why are you having contractions sea level and you're not having contractions at depth, which is the same distance? And even when depth, there's atmospheric changes. This is because at depth, the CO2 is more, let's say, soluble in blood. And therefore your chemoreceptors are not as exposed to CO2 at depth. And therefore, even if you're ascending back from 50 meters, you may have minimal, if no, urge to breathe and 0 to no contractions, which is pretty interesting if you're trying to explain that. Let's go a little bit more.
Juani,
Yeah.
real quick, is there if we're looking for more information on what kind of receptors, like the CO2 is still there, it's just maybe not interacting with receptors, like is there a name for that, somewhere we can do more research on that subject?
Who is this?
This is Hendrik.
Hey man, how you doing?
Hey, good. How are you?
Good. Send me the question on direct message. I can look at some article for you.
Thank
I
you
can
very
look up
much.
some literature. I'd love to, because I don't know everything, you know. But when there's a question, that's a question that needs to be looked at. I believe, and now this is important that you ask. So, I think in freediving in 2022, in medicine in freediving, is not about having the right answers. It's having the right questions, because we know so little, and we learn mostly from the athletes and the community, that having the right questions is better than having the right answers in freediving medicine. So that's great. It's a great question. So I'll be happy to, you send me the question. I'll be happy to look it up. These are other changes in freediving that happen on your brain. And this is a paper published last year that I had the honor of being part of with the Coma Science group that looked at an elite athlete. So they put an elite athlete on the functional MRI, which basically looks at your brain and looks at how your brain functions. And I had the opportunity to look at the raw data and communicate with them. But when a scientist looked at the brain and how it works during let's say a 6-minute dry static on the MRI machine, they couldn't tell why the brain was working like that. So I looked at that, and then I thought about freediving immediately, and I saw that the visual cortex, for example, was activated, and the limbic system was activated. The motor cortex was decreased in activity, and this is exactly what we do in a static, right? In a static, you're trying to visualize your happy place. You're trying to visualize something that would allow you to get a longer breath hold. So your visual cortex is activated. Then your limbic system is activated because you're having emotion. And usually we're trying to do happy emotions or nice or good emotions, positive emotions when we're in a breath hold, static, and a depth. You know, you're in flow state, you're living in the present. There's no past, no future, and everything it's a reward. So there's no wonder the limbic system fires up when this elite athlete was doing a 6-minute dry static. Also, your motor cortex that controls mobility, motion, it's less activated in static breath hold because we're trying not to move. So that really explained everything that we already know, but we were able to look at it on the brain, and that was amazing to see how the brain worked in freediving. So other variables, other things that happen to your body. This is a case report that we published last year as well. I was very, very fortunate to interact with people that have way more experience than I do. And this is the first case of pulmonary edema and prolonged hypoxia on a diver that did a dry static and was very, very noble to share his experience. Obviously, his name is not here, but someone that did a dry static on RB and with facial gear, which I think is a risk factor. Ended up having actually pulmonary edema at home, which is something that makes no sense to most physicians. Why would you have barotrauma or what looks like barotrauma without getting wet? So, and I think what happened here is that when you have prolonged hypoxia, especially with RB, what we saw in the graphic that you can see there, in RB, your saturation of oxygen in total lung capacity will probably have a slow drop, very slow drop with some fluctuations. But your saturation of oxygen on RB has a sudden drop at minute, I believe is minute 3. And that is different than total lung capacity. So static on RB and static on total lung capacity are different. It's a different behavior, different physiology. And in this case, doing it with facial gear on, let's say a mask or a nose tape, I think it's a major risk factor. So it's something you should not do, is do any breath hold alone at home with facial gear. I would be my recommendation to do not do that. Even when the dogma in the past that I learned growing up and taking courses is, yeah, you can probably have a blackout at home in your bedroom, but it will be safe because you're alone and you're in your bedroom. But if you have one with facial gear, you may not be able to recover. So your recovery breathing will be definitely a failure. So why do you need to know all this? Why do we need to know physiology of freediving? We don't think of this when we dive because freediving is a mental and physical self-discovery. In my mind, I'm thinking freediving is something that in the future will be used as a tool for mental health. I personally have been working on this, and I treated at least one of my students with PTSD that got some improvement, but just one person. No, I don't have a lot of experience on that, but I know it could help. And this is important to understand what feels normal and what feels abnormal in freediving. For example, if you have tachycardia after a dive that is sustained for 2 hours after a dive, that is absolutely not normal. And that may feel normal to people that are not well versed in freediving or that are beginners or neophytes, but to the community that have been diving for at least a couple of years, that's absolutely unacceptable. Now, what factors determine who is fit for freediving? Your age, your past medical history. This is very important because a lot of the times, just invite friends that are new to freediving or have taken a level 1 on any course, and you set up a line, you drop a line. Okay, let's drop a line to 30, but that you may not be aware of their medical history, and that's huge. Now, past medical history is something that is private. Lots of people may not tell you what they've had in the past, what kind of conditions or medications they have taken the last week, or drugs. I mean, let's be real. That's something that happens all over the world, especially in young age. Your current physical status and exam is important. And I don't see instructors, doing a physical exam on students, and you're not supposed to, but you're supposed to rely on your student to tell you the truth. Therefore, sometimes the medical statement it's a document done in faith that the student is telling you the truth. It's very important. Your current and past medications is huge, and I'm going to show you a list of medications that I consider a contraindication to freediving. Your past surgical history is important. Somebody has had surgery recently, or had surgery on the sinus surgery, ear surgery, or surgery for a stick and tooth surgery. High risk for having something happen, either reverse block or sinus squeeze, what we call sinus squeeze or sinus barotrauma. And your current physical performance is important, because if your current physical performance is, let's say, 50% of your baseline physical performance, and that has changed in the last month, and you're not aware of it, or you are aware of it, but you don't disclose it, then that's an issue. That's a risk factor. That's a risk as part of your risk assessment. In my mind, their main risk factors for freediving related incidents are lack of formal training. That's common. And we've seen that in the springs around here recently. And even unfortunate death, like 2018, diving alone. I don't care if someone thinks it's okay, and maybe fine, but I don't know, it's very extremely risky. I believe the chances of surviving after a blackout alone anywhere are probably close to zero. Your lack of awareness of one's physical and mental limits, and this I think changes from time to time. I cannot teach you to go to 100 meters because I barely get to 70 meters. But I know that if your physical condition and mental condition is not always the same, and it changes from week to week. And that's why one day you can do a 50-meter dive, and next week you won't be able to even do it, even if your body feels better or more fit physically, but it's in your mind. Your current uncontrolled medical and surgical conditions are important. If you have uncontrolled hypertension, uncontrolled diabetes, uncontrolled epilepsy, for example, that's very high risk. Learning from, let's say, videos and not learning from a person, it's probably, I think, in my mind, and correct me if I'm wrong, if in my mind is a risky behavior. Overlooking your red flags, it's important. Overlooking tachycardia or severe lactic symptoms or lack of sleep. Superman syndrome is something that happened to me once when this is my own blackout video from Roatan, for example. And this is my sort of mea culpa. You know, I made all the mistakes I could make. I made in that day. I changed my diet to keto diet the week 7 days before the comp. I don't know why. And then I did not sleep very well. I arrived the day of the reception, and I announced 50 meters. And then I did the 50 meters, but I blacked out on the surface. And then, I was tired, mentally exhausted. I waited the 2 days as per ADA protocol, and then again, blackout. So, and focusing too much on the target sometimes it's not the best. Now, this is a document that I put together back in 2020, and I delivered to an international medical committee, and they used it for their guidelines. I think it's of use. So in freediving, the body changes that happen in freediving are not the same that happen in a marathon or 100-meter swim or track and field, etc. You know, so the medications are very important. If you're taking diuretics, for example, when you're taking Lasix or acetazolamide, you have to be careful because that can make it can cause changes in your electrolytes like hypokalemia, low potassium. If you're taking Flomax, which is an alpha blocker, which dilates your vessels, that could interfere theoretically with your dive reflex, which is based on peripheral vasoconstriction. This will be doing the opposite of vasoconstriction. So be careful when taking this medication as well for freediving. Opioids, it's an epidemic and it's overprescribed. So if you're taking that, or you know someone who's taking opioids, or this is depending on opioids, be very careful because that can decrease your respiratory drive, your urge to breathe. And as we know, your urge to breathe is your best friend. CO2 is your best friend. Because that tells you when you have to come up. That tells you when you have to end your dive or your static. And if you don't have that, then you don't have your mechanisms for survival. Okay. Benzodiazepines is the same as above. That can decrease your respiratory rate, your respiratory drive, your urge to breathe, and that's what you don't want to lose. Antiepileptic medications. If someone is having high frequency of seizures, let's say once a month or once a week, yeah, I wouldn't feel comfortable with that. You know, a freediver going in the water doing perhaps static, but no depth unless it's controlled. And if there's recent changes, if somebody just changed their antiepileptic medications in the last week or in the last month to a new one or a new dose or a lower dose, or they're tapering off the antiepileptic medications, you know, very high risk, I would say, very high risk. Absolute contraindications in my mind, presence of intrathecal pumps or devices that go into your spinal cord, because those can deliver medications that can get you muscle relaxation continuously or opioids continuously, and that can definitely decrease your respiratory drive. Current chemotherapy for cancer, for example, God forbid, and antipsychotics, because that can affect your behavior and your mood, and that can affect the ability to communicate. Like doing briefing and debriefing in freediving is dogma. It has to be every dive, debriefing, communication, and if that's affected, then that's a risk factor. So mental and mood disorders relative to me are panic disorders, except if you're, let's say, doing a class for someone who wants to learn how to use meditation underwater to relax, then perhaps under a controlled circumstance, perhaps, and that could be at the discretion of the instructor. Severe PTSD may be a relative contraindication, although, as I said, I have experience with one student that reported benefit of PTSD. Tourette syndrome may be a relative contraindication because it may affect your breathe up, your recovery, movements. Absolute contraindications, dementia, I will be very careful because your short-term memory may be affected and the ability to follow commands. Active schizophrenia, axis 1 psychiatric disorder, severe PPD or bipolar disorder as well, may, in my mind, may be an absolute contraindication. Neurological conditions, seizures, definitely. If they're infrequent, maybe once a year or less, and well managed with medications, may perhaps at the discretion of the instructor and the clearing physician could be okay to be in a pool, but sometimes not. Aphasia, the inability to communicate, then it will be very difficult to communicate. If you have symptoms, you're in trouble, and the dogma of freediving is telling your safety, your discipline, your depth, and your time, right? That's what you need to communicate. If you can't, then that's a risk factor too. Spinal issues, cervical spondylotic myelopathy, meaning stenosis of your spinal cord, meaning impingement of your spinal cord, that's a relative contraindication. Why? Because we do movements underwater that can endanger the spinal cord, like looking up, looking down. That's important. Absolute contraindications in my mind: brain aneurysm that is not treated or is not secured, known history of aneurysm in the brain that is with prior ruptured and is not secured, not treated. AVMs in the brain, arteriovenous malformations, tendinal vessels that are not treated, among other severe vertigo, untreated seizures, etc. There's more. Cardiovascular, for example, heart murmur, severe hypertension, arrhythmias can definitely be an issue in freediving, and pulmonary issues, COPD, cystic fibrosis, tuberculosis, severe asthma as well. These are way too many. So if anybody is interested on getting a copy of this, actually you can find it at for free at A International. And if you want a more in-depth list, you can feel free to email me and I'll be happy to send you one. Again, high risk practices, diving alone. Hyperventilation is definitely high risk. And I have to say, this is something that really made me black out in the past by not knowing I was doing hyperventilation. A couple of things that I've observed over the years is upright or sitting breath holding with max packing when we're doing, let's say, a class and somebody wants to do just packing just to try or to learn, and you're upright. What happens in packing is you increase your blood volume, which can restrict the volume of your heart, and that can restrict your cardiac output and restricts the amount of blood that goes to your brain. And I've seen at least one time as someone that was doing that and had a samba sitting dry just by doing packing and sitting. And, you know, that's a risk factor as well. Again, static on dry on residual volume with facial gear. So fast drop of saturation, fail recovery, prolonged hypoxia. So don't do RV statics on dry with facial gear. Or I would go as far as say, try not to do that with facial gear on full lungs if it's unsupervised. So try to have somebody at home, either in the next room or the living room, who knows you're doing that at home. Especially if you decide to put a facial gear, I would recommend not to use facial gear. Yeah, and you know, I may have some fellow freedivers that will disagree, but that would be my recommendation. If you're unable to take the facial gear off, if you're in loss of motor control while you're trying to recover your saturation of oxygen, that's an issue, and that can be a big issue. You know, trying to go into a cave, no lanyard, that's risky. Variable weight, inverse variable weight, like if you're training and you're going down without weight, without neck weight or anything, etc., and then you're carrying weight up, which I have done for maybe stupidly for training, that's a risk factor, especially if you're not having a safety who's watching you at all times. Untrained RV dives and freediving under the influence, of course. Oh, and actually, this is my own video of my own samba at this Blue Hole in 2020. You see me breathing, like you cannot tell that something's about to happen. I'm doing 1, 2, 3 recovery breaths, and then the samba starts after that. So that tells you that you really have to watch someone until they are done with the recovery breathing. Right now it's 1, 2, 3, okay sign, I am okay. You have to watch all that, because that can happen after my recovery breaths. That's when I have the samba. So that's a take home message. So now you pass your medical checkup and you went to your physician and it clears you. The physician probably, most unlikely, they will say, that's crazy what you're doing, but I think you're healthy. Okay, let me sign that. More than likely, that's what's going to happen. And if you tell him, well, I'm be doing RV dives, he won't know what RV dives are. They're tell him, well, I'm doing a hang at 20 meters for 5 minutes. I'm pretty good. He'll tell you you're crazy, and there will be, yeah. So it's not part of mainstream medicine. And so then what do you do? So you seek methodical training. You connect with other freedivers to find safeties. And then you learn from a certified instructor from any agency. That's important. These are just photos from my home country in Peru when I was able to teach the special operators for Navy. All right. If you don't have any questions, I'm going to go into general competition stuff, safety planning. Let's go. So for competition, and I'm going to give you my limited knowledge. I don't know everything, and I have never been a chief of safety, although I interacted with chief of safeties before to just plan and to design a incident action plan and medical evac, etc. But I'll tell you the medical angle. For competition, there's specific forms that you have to follow, at least for ADA, and that helps you plan. You have to have a medical form that has to be signed by the athletes, and this is what I'm showing. It's a good tool. It's a good tool because it's your first line of screening if someone has an issue, but it's not perfect. And I don't think you can find one that it will be perfect unless you do an X-ray, an echocardiogram, a CT scan, and pulmonary function test on every freediver, which it's impossible. Not only is cost prohibitive, but it will be impossible to do it on everyone. So you need to rely on your athletes to tell you the truth and to come up and tell you what's happening. And I have to give credit to, I really have to give credit to Jerome Van Hout, who is another member of the Medical and Science Committee, because he brought to the attention that forms like this tells you that if you had something recently or you have something now, but he brought to the attention of the community, what is the risk of a recent history of lumbar trauma, for example? That has to be a question that has to come from the doctor, the organizer, perhaps, chief of safety, or the judge. And if you have to ask the diver, well, when was the last time you had a lumbar trauma? It's not enough to say yes or no in this form, but you have to disclose how severe it was, how recent it was, what did you do to recover, and if you have recovered and if you have been cleared. That's important. That's recent history, like he said, and it's very, very important. That's probably, I think it's probably unrecognized yet and probably unreported. So that's something to think about. I have to give thanks to your own. There's obviously an assumption of risk, and that's happens for multiple agencies now. There's general recommendations from medical, but I'm going to go through just the basics. I have to give thanks to a lot of people because I didn't make this up. I didn't invent any of this. I have to thank Jonathan Sanix, who taught me like everything I learned from safety, and Roberto, who actually is in the audience. because we worked together for the world record attempt in 2017 in Dominica, where there are very very little medical facilities and no equipment, but we made it happen safely. So the chief of safety is who designs the safety plan and design the roles. The medical team is usually a medic and an assistant. There's some safety drills that have to be done, no question, the week before, and that's up to the chief of safety to determine that, to assign roles, dates, and times. The evacuation route and contact numbers have to be shared by the medical team, the safety team, and the organizer. The local medical facilities have to be accounted for, and they have to be put on standby if possible. The platform equipment have to be, I would recommend to have double of everything, especially in remote areas where it's difficult to find a working AED, a working defibrillator. It's very difficult to find a working, at least in my experience, a working suction machine. Yeah, that's very, very important, at least for a medic, very important. And you have to know the topography where you will be diving. This is, for example, just a rough diagram of the Dean's Blue Hole. This is in Roatan, where you have to be aware the current and the reef. In Dominica, for example, there's about 20 to 30 meter ride from the diving site to the nearest big hospital, at least, and that has to be planned out beforehand. And this is nothing I made up. This is something I learned from experienced people like Juani Valdivia and Chris McKay, for example, and Ren Chapman, who are extremely experienced. I hope that I can make them justice by mentioning them. Yeah, that's very important. And not only if you're planning a competition or an event, but if you're planning training anywhere, you have to just plan that, especially if you have in your group somebody that has some past medical history, some age over 65 years old, and they're trying to push any little limit. You just have to know where is your closest help. This is an example of an incident action plan that I put together in 2020 when there was a world record attempt in Bahamas. So you have to know your limitations, what your risks are, what your risk assessment and your risk mitigation plan, and then plan it out and describe it. This has to be well done before, at least from the medical standpoint, before this happens, before an attempt happens or an event happens. And your medical supplies have to be checked at least 3 times that everything works, and the roles have to be assigned beforehand if there's an incident like needing CPR, for example, as in this case. The platform setup, usually this is not the universal platform setup because each platform setup is different. This is the one I've used in the past when I was in Dominica, and the ones I've seen in other places like Curacao. But usually there's an athletes area and there's a medical area. And the medical area is almost like a mini ER, a mini trauma bay, where the athlete will come in, and that's the center of attention. The medical team, comes into play, and then if it's a serious event, the medical team will direct the safeties to come into the platform and help, because everybody has a role. So these are other examples of incident action plans from other very experienced people like Ren Chapman, who I really look up to, put together this for a competition in Roatan, outlining every single plan to mitigate every single risk. And that's what exactly needs to be done. Unfortunately, everyone that I've seen in all these places, I feel completely at ease that if something happens, someone will take care of me. And that's what you should feel when you go to one of these events. This is a document from Savas outlining the basic counterbalance mechanisms. And this is all available in the literature. This is something I didn't make up or I didn't invent. You can find this online for your own knowledge. The basic platform setup is, as I said, your basic first aid kit. Your suction machine has to be working, it has to be powerful. Your defibrillator, a DAN kit with regulator, and a separate O2 bottle with a regulator for potentially breathing on the platform or breathing underwater. Now, I won't be recommending that this is what you should do, but it's done. So some divers will recover underwater, let's say at 8 meters with 100% O2 for just a short amount of time. And there's 2 camps on this. There's a camp where Many freedivers will think that's the right thing to do, and there's another camp that's saying absolutely not. You shouldn't do it because oxygen toxicity, and those are behaviors that happen in the freediving community. And I cannot tell you which one is the best one. I can't. I just don't have enough information for that. So, your minimum requirements are 6 experience. Ideally, safeties that are well versed in BLS, at least basic life support, and ideally advanced life support, if possible, if there are some sort of medical background. 1 medical paramedic, a fast evacuation boat, ideally a vehicle, evacuation vehicle, or well-equipped ambulance. Forget about the scuba. That's a mistake. The roles are chief of safety, safety team, judges, medic, announcer, and coach. And this is sort of what you see before you're going down if you're an athlete and you're the first time competing. And I have not been to many competitions, and I haven't been to all of them. I've been to a handful as a competitor, and it's a lot of fun. It's a lot of fun because it's competing against yourself. I feel you don't compete with others, but I feel competing against yourself and setting mental and physical goals to yourself. Every time you break those, it's a big breakthrough in life. It makes you just be a better human being. So this is what you will see. You'll see the medical team on one side, the judge and the announcer on the other side, the divers around, the safety divers around you, and then you if you're the diver. So these are different arrangements. These are photos of when I was assistant medic in the past, and I believe that's you, Roberto, in the platform. Yeah, I'm pretty sure that's you. This is Dominica. So we went through this. I don't know if I need to be very, very detailed, specific about what equipment you need to have. If you want that, I'll be happy to send you a copy of this, or photos of what I have. But you need to check your equipment, make sure it's chargeable, make sure it works, make sure the tank is full, make sure the oxygen tank is full. That's very important, especially in remote areas. Let's see if I can keep going. So the drills, these are actually drills from 2017 when we're practicing for a world record attempt. And this have to be done religiously, I believe, because your muscle memory and the memory mentally on the steps have to be in tune before the event, way before the event. The roles have to be very clear and assigned. When to do blow tap talk, or after how many rescue breaths you have to get the diver out of the water. The mechanism of extrication from the water, that has to be practiced, because at least one time I've tried to get a diver out of the water and I fell myself face backwards into the platform and hitting my back, and because I just didn't practice before. It may seem very self-explanatory, very simple, but if you don't practice, things can happen. Things happen and deviate from the process that you want to happen. Usually, to extricate someone from the water is 2 moves. One is to get the upper body into the platform, and the second pull is to get the whole body into the platform, as you'll see here. These are movies from back in 2014 or 2015 when I was just in I was just going to Vertical Blue to watch and to learn. I just knew that there was something special about freediving back then. I didn't know what exactly, but I saw this brain behavior and neurology that I've never seen, and that really, really hooked me into this, especially the medical part. So these rehearsals are everything, and I saw this practicing days before the comp. I think that's very, very important. Everybody has a role. Everything is well rehearsed before any event, and that helps you. It helps a lot. These are more photos of our rehearsals back in December 2020, where we're practicing with the judge, and everybody was trying to find their perfect role. Again, someone takes care of airway, someone takes care of ambu bag, someone takes care of the defibrillator, someone has the code drugs, someone has the Dan kit, someone does compressions, and has to be well planned out before day one. Before I continue, any questions? I think we've done almost an hour.
Can I ask you a question, Juani? This is Ollie.
Yeah. Hey, Ollie.
Hey, very, very interesting. Just a quick one. In case of an underwater blackout, so if the blackout happens on the way up, would you suggest still to do blow talk or blow tap talk, depending on the agency, at the surface, or go straight for mouth to nose?
Yeah, that's a good question. So number one, I have to state another disclosure. This talk and what I'm giving you today is not official ADA statement. Every single material I'm giving you is not official ADA material, and I'm not speaking for ADA or any agency. These are just my recollection of just an experience over years. Now, if it's a very important question. So starting with the premise that the most important thing is to protect the airway, and that the airway needs to be above water at all times, because if there's a blackout above water or underwater and the airway comes up and then there's another facial immersion again, I believe that lengthens your blackout. Let's say if you have an underwater blackout and you come out of water, your face already has receptors that tells your brain, you're up, you're out, it's time to breathe. But if you have facial immersion again, your brain is saying, okay, you're out of water. Okay, wait a second, you're out, you're under again. So you continue with laryngospasm and no breathing, right? So you have to keep that airway above water, face above water. It's number one priority. If it's a blackout that happens, if it's mild, which is considered to be at surface, keeping the airway, blow tap talk perhaps is okay. As I've seen, and you've seen probably innumerable circumstances, including my own, where I just blow tap talk and I was back and I didn't even know I had a blackout. But if it's an underwater, let's go to the opposite, underwater blackout, which high likely of pulmonary issues added to it, and that will make it a extremely severe blackout per ADA, then doing blow tap talk perhaps is a waste of time. Doing blow tap talk would be, if you're just come up doing blow tap talk, hoping for somebody unconscious, almost drowned, to wake up, will be a waste of time. You have to get that diver out, extrication immediately. Yeah. Does that make any sense?
Absolutely. That's my observation as well. That surface blackouts, you don't need to do anything else than blow talk or blow tap talk. They come around. But if the blackout happens below surface, it feels like a waste of time, in my experience, to go for blow talk first. Go straight for rescue breaths, and that solves the issue. If they're done the right way, I think that's a very important part, that they have to be done, executed the correct way, with opening the airways first, then give the rescue breath, and not try to blow before tilting the head backwards. And then there's an immediate response.
Yeah, agreed. Yeah, I don't know if there's, this is my opinion, obviously, there's multiple opinions that, blow tap talk may be antiquated, etc. But I've seen it happen. When I had my own blackout twice in 1 week, blow tap talk is what saved me. And I didn't know I had a blackout. I woke up and I
agree.
Kept saying,
blow
I'm
talk,
okay.
blow tap talk at the surface, when you come up on your own propulsion, you're doing recovery breaths, and then you go down exactly as you showed in your own video, of yourself. Then blow talk is enough. That's my experience as well. Yeah.
Now, the other situations that happen, like trismus, for example. Trismus is the contraction of the masseter muscle, so the jaw is completely closed and you are unable to open the mouth. That's the freediving medics' nightmare, because then how are you gonna get the airway? So then you use mouth to nose ventilation. Yeah, because then you can bypass the mouth. And then on top of that, when there's laryngospasm, meaning there's closure of the vocal cords, which is a reflex when there's loss of consciousness, then that's a bad situation, because you have to try to wake up the diver somehow and make sure the airway is out to allow the brain to be aware that it's not underwater anymore. Yeah. So
Johnny, I have a question as
yeah.
well.
Hey Scott, how are you?
Hey, good buddy. Sorry, I jumped in kind of late, man. I just landed in Miami.
Oh, good, man. Good to see you.
There was some debate a bit about whether to go recovery breaths mouth to mouth or mouth to nose. Talia and I were discussing this not long ago, and it was, I kind of like the mouth to mouth situation, but there's been discussion of the receptors in the nose being more responsive when you go mouth to nose. But the problem then you run into is, what if your soft palate's locked shut and you're going mouth to nose and you don't realize that? Do you have any thoughts on that?
So first of all, yes, you're correct. The trigeminal nerve innervates the inner part of your nostril, and that's the same nerve that innervates your face, and that's the same nerve that goes all the way back to your brainstem and tells your brain we're above water.
Sure.
So yes. So doing mouth to nose theoretically can trigger that, but so I think if you're doing mouth to nose and it's going nowhere, then you could assume that either two things happening: either your palate is locked up, or the vocal cords are closed, both of them, and that's a nightmare. So I would prefer, just because you can get a bigger volume in, mouth to mouth. Mouth to nose is a closer airway, it's a smaller airway diameter, so it's less flow, and then mouth to mouth would be ideal. But that's no dogma. That's my recollection.
I think that's kind of our.
Can I?
Oh, I'm sorry. Go ahead.
Oh, I'm sorry. I was. This is Bizo here.
Bizo, how you doing, man?
How goes it? Thank you for an amazing presentation. I was listening to Ollie speak, and I would totally add into what Scott is saying there. I was wondering, and I'm just gonna throw it out there as an idea. And of course, that would depend on the situation, on the logistics of the platform, how easy it is to take the diver straight to the platform. But what if, in the situation of a underwater blackout, that you are much more likely to have a prolonged blackout and more trismus, glottic spasm? How about just take this diver straight from underwater to the platform and stick a NPA in the nose, and start suctioning right after the moment, right on the platform, you suction, you put an NPA, and then you're in a much more controlled environment to deal with this airway.
No, I think that's exactly what should be done. Yeah, and try to control secretions, and just by turning the diver, using the suction machine. Yeah, I think exactly what should be done.
On a surface blackout, blow tap talk, much more likely to recover, but an underwater blackout, you're probably looking at longer recovery times and more likelihood of spasm and trismus.
Mm-hmm.
A NPA would be like a really big shortcut right there.
Yeah. Now the question is, when
can you quickly explain what an NPA is?
Oh, I'm sorry. Is a little rubber. If you give me 3 seconds, I'll get one for you. Is a rubber tube that goes in through your nose, that passes the distance goes beyond your soft palate, so it gives you a direct access to the supraglottic area.
Mm-hmm. So it's a tube that goes through your nose,
through your closed mouth or a floppy soft palate. You just go straight to the supraglottic area.
Correct. Yeah, correct. I wish I had one with me right now, but
I have one here. Give me 3 seconds.
Yeah.
Of course, everybody needs to have an MPA at home, right?
Yeah. So one thing I was going to say is how do you, after Biso comes in, I'll continue.
This is it. It's basically a soft rubber tube that you lubricate, stick in the nose, and goes past your soft palate.
Yeah.
And then you can either suck stuff out or put air in.
Correct.
Interesting.
Yeah. Now the question is, yeah, when do you do it? Do you do it right away? Do you wait for, if the diver is trying to take some breaths? Yeah, I wonder if we should just put it. Yeah, difficult. I think it depends on the mental status of the diver, right? If the diver is trying to wake up and you're trying to put a tube in, that may be difficult. That may create some trauma. But if the diver is completely unconscious, then yeah, I see where that can fit. So the self-test for respiratory barotrauma is just to know sort of when is good and when is bad. You know, if you, usually what I do is I ask the diver to exhale forcefully, and if that induces cough, then I think it's lung barotrauma, not upper respiratory barotrauma. If it's dyspnea at rest, usually I'm very concerned. If it's dyspnea on ambulation rather than at rest, then I think there's still a problem. And then I usually do pulse oximetry at rest versus ambulation. So if I ask the diver to sit and to take the pulse oximeter, and let's say it's 93, and then I ask the diver to just walk for 10 minutes, and if that drops to 83, then I know that's something obstructing the gas exchange at the lung level. So lung barotrauma. Now for lung barotrauma, or what we call lung squeeze, you know, we do pulse oximetry. The cheapest test you can ever have is a chest X-ray if you're concerned. Although you can have lung barotrauma with a normal chest X-ray. And if you're home and you really, really want to take a look at your lungs, the expensive test will be the high resolution thin cut chest CAT scan without contrast. If you really want to take a look at the tissue, and obviously you have pulmonary function tests. Let me go forward a little bit more on this because we're running short of time. Any questions before I keep going? I have the last part.
Yeah, Juani, I just have a question. This is Daniel Alviar. I joined a little bit late.
Hey, Daniel.
I'm Jamie Giuliano's partner. I'm going to be teaming up with her at Vertical Blue this year. But just out of curiosity, has anybody done any studies for lung compliance pre and post dive on any measurement? So you know how they have the, you know, when you get cardiac surgery in the hospital, or they do the sphygmometer, where people see their lung compliance ahead of time, pre-competition, just seeing like a difference as far as baro capacity, how they perform, you know, how much they can breathe in post dive versus pre-dive. Does that make sense?
You mean with a spirometer?
Yes, sir. Yeah, I'm just wondering, you know, how much from a pathophysiology standpoint, you know, that the diver might feel okay, but you know, I'm wondering, have their lungs truly re-expanded, or you know, do they take seconds? Do they take minutes? Do some people go walk around? And because everybody experiences the lung squeeze, and obviously it's different for everybody, but I'm just curious about how long it goes on for, and really what's their capacity when they come back up versus from 100-meter dive versus, you know, a 50 or you get what I'm saying, I'm sure.
Yeah, it depends on the diver. Depends on the age, the physical status, their training status. Yeah, I mean, and if there's pulmonary edema, I guess I don't think everyone will have a saturation of 100% right immediately after a dive like that. You know?
Yeah.
For a number of reasons, you have peripheral vasoconstriction, so therefore your sats may be abnormally low when it's unexplainable, or you may just be low at 90, and then after 10 minutes you'll be 95.
Right.
Or after a deep breath it will be 97. So I think it depends on every diver, but I don't know if there is any study like that. No, not yet.
Yeah.
At least.
I have done some stuff with ultrasound, small number of patients, kind of matched what Erica Chagatai's study did with ultrasound. Like the deeper you go, the more B lines you have. But I also noticed what Juani just said. I was diving in a group with a bunch of like intermediate to advanced divers, and then Dan Koval, and Dan would come out of the water after a 105 meter dive, pink as a baby's butt, without any beelines on his lungs and setting 99%, and me and other average simple mortal divers coming out full of pulmonary edema and lower O2 sats. So the general trend I noticed that is, makes sense, but it does make a big difference if you are a badass diver or not.
Yeah, that makes sense. Yeah, because they can clear those fluids a lot faster than you and I, for example. I'll catch my breath for a couple of minutes after a dive. I mean, after a 50-meter dive.
I think a lot of that is adaptation, because Daniel's in the water almost constantly at home.
Yeah.
And yeah, adaptation is I think key there.
Let me show you a couple more things here before we run out of time. Oh, wow, let me see. Let's see, okay, here.
I want to ask a quick question. So I want to ask if there's a time limit when we can have the CT scan for the lung barotrauma, because I had a buddy who had all the symptoms of a very serious lung barotrauma, the coughing with the blood, extreme tiredness, shortness of breath, and it went on for 3 days. But when he had the CT scan, it was completely clean.
Yeah. And when did he have the CT scan?
5 days after the squeeze.
Yeah. And was he having symptoms when he had the CT scan?
No, it was getting much better. Yeah, so he didn't, the tiredness and everything. So is it possible for the squeeze to heal that fast?
Well, the squeeze is edema. It's fluid on your alveoli, and it could have been cleared by the time he had a CT scan. Or he had a tracheal squeeze instead of a lung squeeze. So that won't show on everyone,
And the tracheal squeeze could actually result in the shortness of breath and extreme tiredness?
Yes, because it's like asthma. It works like asthma. You obstruct your airway, so it'll make you cough, and you'll feel short. You'll feel some dyspnea, and it's that's why it's difficult to know when it's upper respiratory squeeze versus real lung squeeze. And yes, you may think, oh, it's just my trachea or it's my lung, but it might be the opposite. So potentially on him, he was an upper respiratory barotrauma that obviously won't show on a lung CT scan.
Okay.
Yeah.
Good. Thank you so much.
Yeah, I wanted to show you some slides.
Actually, the question if it can heal that quickly is really interesting. Vitomir did some research on that, where he took a free diver who came up from 100+ meter dive who was spitting blood at the surface in a way that people thought he's going to die. And he took him straight to the hospital, did CT scans, and they couldn't find the injury like 6 hours after the incident. They couldn't find it anymore. So healing processes seem to be very different from what we actually even 2-3 years ago expected what they are.
Interesting. Let me see if I can show you some general stuff about blackout. This is a poster presented last year with some interesting findings. This is nothing I came up with. This is public knowledge. I just work with a fellow freediver who was just has a way with numbers, and it shows the percentage of red card and red card with DQ blackout in 10 years of freediving competition for ADA. Again, this is public data that is accessible for everyone. And so it's 3% of DQBO red card in all 10 years. So, and because the way they recorded the data was not LMC or blackout, then one can assume that DQBO red card is a blackout. Therefore, we took that. And now the real number of blackouts may be even higher than this, or LMCs may be higher than this, but that's what we assume, that there was a blackout. So now this is obviously percentage of by discipline and gender, and across all dives in competitions, you can see that the percentage of DQBO doesn't change quite a lot from year to year in 10 years, in between 2.5 and 4%. There's no big jumps in 10 years, but there's differences and mild differences in disciplines for static, pool dynamic, and depth. Interesting that pool dynamic is higher than depth. And, that really caught my attention. And now this is obviously something that we probably expect, that CNF has higher incidence of DQBO than other disciplines, because it's the most demanding one physically, where most of your oxygen is used. Now there's a gender difference. I don't know if this is a statistical significance, so I can't really draw any conclusion from this. There's more DQBO in obviously depth. If you announce more than 100 meters, and the more you announce, the higher the chances of having red card DQBO in those 10 years, which is, it's just sensical. It makes sense. If you do CNF, higher chances of DQBO or blackout, especially if you pass. There's a big jump between 70 and 80 meters, and 80 and 90 meters. There's a big jump in those 10 years. It's almost double the incidence of DQBO. And this is comparing if you're announcing a percentage of the world record at that time, and you're announcing, the closer you are to announcing to the world record, the higher the chances of syncope or blackout. So now, this is something that I presented as well at that meeting. This is my own idea of how hypoxia in freediving happens. I don't think all blackouts are not the same, number one. And it all depends on each person's age, past medical history, medications, etc. And there's not only one clinical presentation for blackouts, but there's multiple. Just like there's multiple types of seizures, for example. There's one called petit mal, and one called grand mal, and one called absent seizures, partial seizures. So I feel like the progression, the clinical progression of hypoxia starts at normal consciousness, and then one has something that is called asymptomatic hypoxia, meaning you're at the threshold of hypoxia in regards to brain functioning, and you just don't feel it. You just are not aware of it. You don't feel it, and it's probably likely on ascend. And then probably the time between that and having symptoms is probably a second, if not less, or a few seconds. And it's controlled symptomatic hypoxia, where the diver continues to ascend, but already has a sensation that something's wrong. Now, I have to thank Oleg Melikov, because he helped me kind of design these names: asymptomatic hypoxia and then symptomatic control. When, for example, one is doing free immersion and you're still pulling gracefully, and you feel that something is off, but you don't know what. And I feel like according to a top level athlete that told me this, that the more trained you are in freediving, the higher the chances that you will be aware that something's wrong. Like elite athletes like William, for example, they know exactly at what depth, what sensations they should be having. Unlike me, that I'm quite unaware of that. So they will know that something's wrong. And by the time you're ascending and you know that something's wrong with your mental status, you're already in trouble, and you better have a safety next to you. Why? Because your awareness is already impaired if you're hypoxic. Now then you go into loss of motor control, which is basically tremors. And that can be conscious, like the video you saw of me. I was fully conscious, but I still had a samba and I didn't lose consciousness. So I have full recollection of the event. But then that conscious LMC can going to unconscious LMC, when you lose consciousness, you don't have recollection of the event or memory of the event, and then you're still shaking, right? That falls into unconsciousness, or what I call freediving related syncope or blackout, which can be atonal BO, which is when somebody's completely lost of tone, when it can be unconscious LMC, or it could be a disturbed posture blackout, where the diver extends the arms and arches back. That's called disturbed posture. Or prolonged hypoxic BO, when someone is in a state where it's hypoxic and is unable to properly recover. So yeah, that was that's sort of my take on hypoxia, and this is with permission of John Mochi from Colombia, who I just got confirmation I have permission to show this. You can see that. Oh wait, you can see that he's ascending, and he's got. This is a good video to know the signs of hypoxia underwater. And John is an amazing freediver and instructor. So he's going up, and you see him looking up and changing his form, already not being hydrodynamic anymore, not being streamlining, and slowing down even before. And you see a small shake just before hitting the surface, and he was already having LMC underwater. So by the time he hit the surface, he was unconscious. He had 3 recovery breaths, and he was able to get back in consciousness. And I believe this is in San Andres. That's important because for the safeties, that you can see these signs underwater: change in pace, change in form, change in technique, change in propulsion. Yeah, that's important. You know, it's something that probably the most safeties that what we call clinical eye will be able to catch sooner than others. And then the conscious LMC is like this one, where you go up completely conscious, doing normal, looks fine, and then the LMC starts. And that's thanks to Chris McKay, was able to hold my elbow, and then I stayed up. So it's conscious LMC. And then unconscious LMC is like this one, which is also my video of my own blackout, where I'm coming up from, I guess, 50, and you see me doing all the mistakes, all the bad mistakes, you know, kicking with my legs and doing very fast pulls. And I don't know why my goggles were already up. Yeah, I made all the mistakes possible to black out. And then you see me doing this LMC just before hitting the surface. That was the sign that things were over for me. And I feel like the LMC is not just shaking, it's not a erratic shake. It has a pace. It's almost like a seizure where there is a pace, like 1, 2, 3, 4, 5. It's all paced LMCs, and they're all very similar pace. So that means that LMCs are similar, or if not equal, from diver to diver. Number 1. Number 2, LMC happens on muscles that are trying to act. Like if you're trying to do the OK sign, your biceps and your triceps are acting against each other. Therefore, you're doing the LMC 1, 2, 3, 4, 5. And also your anti-gravitatory muscles, your erector spinae who keeps you upright, and also your quads that keep you standing. Those are the ones to activate in the LMC. And you see me here arching back and kicking with my quads down like this. Yeah, that's LMC. Yeah, it's not just shaking on your hand. It's the anti-gravitatory muscles that are activated on an LMC. That's my opinion. Meaning there are muscles that make you arch back and that kick your legs. Yeah. So, and then, yeah, I won't show this once, but yeah. Any questions? I think we went through a lot of stuff. I have a lot of videos here, but I'm not gonna bore you guys with more.
I have a question.
Yeah.
This is Yessie. I had some of the questions that you addressed throughout the presentation, like medical history and drugs that could be conflicting with freediving. But I wanted to ask you personally, what has been your best and worst experience as a freediving medic? Or in
I think number one is, I think it's more stressful to be a freediving medic than being a freediving competitor. Because as a freediving medic, everybody's life is on your hands, and if the medic of a world record attempt that is very, very deep, past 100, yeah, of course, I mean, you're responsible for someone's life, and that's added to my job. That I see that on my job every day. That's a lot. I wish I was on vacation, but I'm doing the same, I guess, when I do that. But something very stimulating. It's very stressful. I guess my worst, let's see, I think my most stressful situation was when the equipment was not working, or when I was unsure that the suction machine was not working and I was not perhaps ready. That's probably my most difficult time. And the best time is when I feel like when you're a medic in a platform, and I have to, and again, I have to give a lot of credit to very, very good medics. Like Hector Ruiz is a very, very good medic. He's a physician and he's been in Curacao, and in Roatan numerous times. I believe he's been in Curacao as well. And I learned from him actually a lot. Tomar Dabani is the first medic that ever told me, hey, you want to be assistant? The first one. So I have to give credit. So as a medic, there's multiple low stress situations like surface blackout, cough, maybe light squeeze, multiple, until it happens, boom, underwater blackout. So it's multiple mild ones, and there's a big one. And that's sort of like the flow of being a freediving medic. So I mean, I guess the best one was when there was a mild blackout and things were fine and people smiled, and yeah, that's all I can remember. Yeah. I see that there's a lot of people in the audience that are very, very experienced, like Jaime Moreno. Jaime, how are you? Dr. Jim Chimiak as well from Dan Medical. And I think we're coming to the end. So I think that the purpose of this talk was to just do a little review of the topics. And again, initially this was supposed to be a very small seminar for the local freediving community here in Florida. And then somehow everybody showed up, and I'm really happy that I was able to share with you guys my passion for this. I think what's coming in the future is just doing more research and just working with like-minded freedivers and contributing with medical assessments to freedivers in the USA Freediving Federation, hopefully ADA USA. And I believe that this should be done for free. You know, I've been doing this, I think 2016. No cost. And I think it should be continued like that, because I think freediving is so new that every one of us in such a small community should have access to care, no matter what, no matter the money or what you do. Yeah, I think healthcare in general in the US is the most complex healthcare in the world, and the most obstacle-ridden. That if you have insurance, if you're covered, if your age and comorbidities, pre-existing conditions, that freediving is such a growing sport that everyone should have access to someone who can assess your freediving medical history for free. That's my message. So I don't know if you guys have any more questions, but I really thank you so much for being here, and hopefully I'll see you soon and we'll be able to dive.
There is a message, a question in the chat, Juani. I'm not sure if you can see it.
Oh, well, let me see.
There's a Christian ask, Juani, what are your personal experience as athlete in recognizing your signs of hypoxia, both pool and depth? I believe this changes from athlete to athlete. That's the question. So for you, as an athlete,
I don't know. I think that's you know, I think saying that there's this list of things that you will feel and will tell you you are hypoxic is misleading, because that changes from athlete to athlete. I know that if I feel something's wrong, I might be hypoxic, I am already in trouble. because my perception is already altered. So I just rather trust that my safety is with me if I know something's wrong. If I know that I don't know where I am, what depth I am, how close to the surface I am, and what's my propulsion. If I'm just not aware as a whole, I just know that something's wrong, and I just trust that my lanyard's on and my safety was waiting for me. So I don't know there's a formula for that, but being unaware of your surroundings, time, location, and being disoriented, that's just a recipe for disaster, and that tells you that you're hypoxic is more likely.
I can totally second that. We asked that same question for when we developed the Wave 4 manual, which we just released now. We asked the same question to the top athletes for the pool. We wanted to know, like, how do you gauge when it's time to come up when you are competing for a gold medal in a world championship? That's quite an interesting situation, right? So, and it is actually interesting that it's very individual, this experience, what Alexi reports in that situation compared to Vitomir, compared to other top athletes in a dynamic, for example. How do they know when to come up? It's very individual, but bottom line is you have to be a lot of time in that area, in that zone, to get to know your own experience, how it feels when you get close to the limit.
Yeah, and what I've heard from freediving athletes, well, not top or whatever level, is that some describe a very pleasant feeling, a very pleasant, dreamy, floaty sensation before a blackout. Because imagine if you are doing a static or whatever, and it's difficult, and somehow it becomes very easy. That's probably telling you it's time to go, it's time to come up. If it's contraction, and it's a dreamy, floaty, then that's something wrong there, because it doesn't make sense to be very hard and then becomes very easy. So that change, to me, it's just common sense. That's hypoxia.
Alexi's experience is like he feels totally in control of a dynamic dive until to a point where he feels a little less in control. That's his indicator that, okay, it's time to come up. That's all he can say about that. Like the rest is sort of steady for him, but this losing control, just a tiny bit, he's not out of control, but he feels like, oh, something changes with how I feel I'm in charge of this dive. Then he stops it.
Yeah, the neurology of freediving and freediving syncope is just something new. Memory, for example, if you ask somebody that blacked out, if they remember immediately after the blackout, they won't be able to tell you. But sometimes memories come the night of the blackout. Then you remember your ascent. Then you remember how you were grabbing the rope. And then the next day, your memory comes back from the incident that you remember, oh yeah, I remember how I grabbed the tag now. But the moment of just recovering from the BL, you don't remember. You lose short-term memory. That happened to me. I completely, I didn't have recollection of the event from when I was doing my breathe up to when I woke up. But 2 days later, I started remembering everything until I blacked out.
So it came right back without the trigger. It just came back to you.
No, it just came like I was having coffee, and I said, "Oh, yeah, that's how." I remember grabbing the tag now. I remember when I turned, and I remember I was very excited and euphoric, but I didn't remember that on the platform when I was waking up. So, just there's something to be said about the symptoms that happen after a blackout. That's something I submitted to UHMS about the post-hypoxic, freediving post-hypoxic syndrome, which is, it's akin to the post-concussion syndrome that happens in NFL, in football. Players that have a concussion, they will have these symptoms, like any concussion, for weeks to months of memory changes, mood changes, insomnia, changes in affect. Now, what happens, let's try to compare that to freediving. If you have a blackout and it's significant for your level of training, there must be something that happens afterwards. And I sent this anonymous survey through social media back in 2018 when I had my blackout. And most freedivers described that they did have some symptoms anonymously after a blackout, like insomnia, short-term memory issues, like forgetting where your keys are, forgetting where your phone is, and the inability to sleep well, mood changes that happen after a blackout. So the blackout is not just something risk-free. And like, people like in a committee like Frederick talks about the severity of the blackout and then the need for awareness. The blackout is not just something mild. Like, even when nowadays we say, okay, that was a mild blackout, you can just dive in 2 days, maybe 3. We still don't know what happens to your brain when you have a blackout. We don't know if it triggers deposits of protein or plaques in your brain, or you accelerate degeneration in your brain. We just don't know that. And we won't know that until the next 30 years when all the community has had a lot of blackouts. They show up at the doctor, have a bunch of brain scans, and then we say, oh, yeah, this actually does change the brain. But we don't know that yet.
We don't even know the consequences of hypoxic states, repeated hypoxic states, not even blackout or in a place where you can see any symptoms of hypoxia, but just putting ourselves in hypoxic states repeatedly over and over again. When you train hard several hundred times per week, possibly. Yeah. We don't know what's going to happen in the long run. There's indications in both directions, what I can see from the data that we see.
I asked, who I asked once is Aaron Solomons. I asked him if he has noticed anything abnormal in his health after so many decades of freediving. He told me no, he cannot tell that anything is really detrimental for him. And he's a man of age that still practices and has practiced since very young. And he could not recall that something has hurt him from doing freediving for decades. So that's good. That's good. That gives me hope,
I wish I could be as positive as well. I can definitely feel a change from now to let's say 25 years ago, but I don't know what caused it. Was it being a freediving professional for now 12 years, or was it the third concussion that I had 20 years ago? Who knows? Like, everything's overlapping.
Yeah, I'm gonna put here my contact info. If you guys want anything from me, be happy to share any documents. Let's see if I'm putting my number well. So if anybody has any medical issues where you need guidance, I cannot give you advice, but I can give you some guidance. I'll be happy to. Those are my numbers, my email. If you need anything, I'm not promoting for any agency, but be happy to do anything for you guys. And thank you so much for being here. This ended up being a big party, and I love it. It's very good people.
Hey, Juani, before you go, hey, this is Lee, and just want to thank you for your passion with freediving and medicine and putting it all together and answering questions and figuring it out and doing studies. And it's pretty cool. It's pretty amazing. You brought it forward a good couple years now. Thank you.
Hey, it's amazing to learn from you, Lee. I was hoping to see you this year, but hope to see you soon. And I miss you. And I really will learn a lot from you. And when I was at Vertical Blue and you were at the platform, you just know that there's no weight on my shoulders. There's something to be said that when you are about to do a performance dive, the people that are immediately around you define your success to a degree. The people that are immediately in your surroundings when you're about to let go, quote unquote, in a performance dive, really help you and help you a lot. And I think you're one of them.
Oh, thank you. And I've always believed that, well, thank you. That is so nice. One of our jobs on the platform, despite it being so benign, is to actually be quietly encouraging to the diver that's going in, to show the confidence that they're going to be okay. We're going to take good care of them. And hopefully they dive with, some confidence that it's going to be all right. And that's part of our job too. So It's pretty
Yeah.
important. So
Yeah,
thank
no,
you.
thank you so much. No, thank
Nice
you
meeting
for,
everybody.
yes, thank you everyone. If nobody was having any more questions, I'm not gonna I'll be out of your hair, and dive safe, and hope to see you soon.
Thank you very much, Juani. It was awesome.
Thank you so much. Have a great night.
God bless us. Cheers. Bye.
You guys.